can hear me, the microphone is having some issues this morning. We'll try to fix it, but in the meantime, I'll try to raise my voice so you can hear. So every year when we have interviews, we kind of like have the faculty give the presentation. So in the next couple of weeks, we'll have the director of OB speak and the director of ethics. And every year I have to kind of like choose a topic that's going to be relevant for the incoming medical students. And I think last year it was PGS, and 2 years ago it was donor egg and donor sperm. So I think this is probably the most relevant topic, given that egg freezing is on the rise. So we're going to try and delve into that project, because I'm sure that as incoming OBGYN resident, you'll get a lot of questions about it. And you want to at least sound smart that you know what you're talking about, right? So, I have nothing to disclose. The objective of today's talk is to review the scientific background and review the current technology of egg freezing, and to try and summarize and interpret some of the clinical results and how do we implement that in our own OBGYN community, among our general OBGYN and our residents, and to discuss options of counseling patients. So this study by Fadi et al. In 1992 was really very pivotal in trying to explain why is it important to try and at least plan ahead or try to get pregnant earlier if you have the right partner. And you can see here that women are born with a finite number of eggs. So at the time of 20 weeks gestation, a female embryo will have roughly about 6 million eggs. That goes down to about 2 million eggs when you catch that baby girl in the labor and delivery on the 6th floor. And then by the time that baby becomes 9, 10, 11, and we get into menarche, only 400,000 eggs are left in that pool. Every month there's about 750 eggs that are being or competing for that release of that one egg. And on average, between age 11 and 51, which is the average age of menopause, a patient will usually release about 400 eggs. Some of them will become the next president of the United States, as you know. So what we see here is a significant decline in the egg quality that obviously reduces the chances of fertility and increases the risk of miscarriages. And that happens already in the 30s. A lot of people think that, if I'm not ready by age 38, 39, that's the time to freeze eggs. I'll tell you today how important it is to have that discussion with your patient at a much earlier stage, so you don't have to miss the boat, so to speak. You can see that the age of menopause is roughly 51 in the US, and you can see that irregular cycles begin at age 45. Most centers would not freeze eggs beyond age 45. Some will cut that age to 40. And there's a push towards freezing eggs sooner and doing it once rather than doing it 3 or 4 times when you're in your late 30s. So this graph shows the decline in the chances of conception just in a natural cycle. So you can see that at age 30, if a couple is trying to conceive and they're having intercourse in the right time when the patient is ovulating, and that's without any fertility workup, roughly it's about 20%. So the best time to get pregnant is really when you're in college, when you're trying to avoid getting pregnant. And then at 30, the decline starts to show. When you're at age 40, the chances of getting pregnant is really just 6 or 7% per month. That's what we call the fecundity rate. So when we sit with a couple who are struggling with infertility, that's mind-blowing to them. They think that as long as they're with their partner in the right room, with the right music, and the right wine, it's going to happen. And it really goes down significantly beyond age 38. So that's part of our job, to educate our team, educate our patient, and take it from there. This is another study that was published at the first and third, and showing the rate of aneuploidy with age. You can see that at age 30, about 23% of embryos are chromosomally abnormal. At age 35, it's already about 35%. And at age 45, 84% of embryos will be chromosomally abnormal when tested with what we call pre-implantation genetic screening. This is a study of Nature Genetics showing the increased risk of miscarriages, and we know that the only way to avoid miscarriages is either testing the embryo before we transfer it into the uterus, or getting pregnant at a younger age, which is not always a feasible option. This is a study at New England Journal of Medicine showing, again, the rate of spontaneous abortion. You see that yellow curve or orange curve, and at age 40 to 44, more than 50% of pregnancies will end up in a miscarriage. And then at age 45, you can see that it's reaching 90 to 95%. And the rate of fertility goes down as well. This is how a karyotype looks like, and this is an abnormal chromosome 10 or trisomy 10 here, whereas this one is a normal chromosome number. In the past, when we used to recommend doing an amniocentesis, it was advised to do it at age 35, and the reason for that was very simple. The risk of miscarriage after doing this amniocentesis was about 1 in 350, and that was roughly the rate of Down syndrome found on those embryos. So they felt that at that point, risks, are below the advantages, so you'll do an amnio. We know that that's no longer the case. A, because we can test so many other things. We no longer use FISH technique, which was limited to chromosome 13, 18, 21, X and Y, and we now can do a full panel, next generation sequencing, and you can find small lesions, duplication, you can find monosomies, trisomies that were never tested before, so the rate of findings is going to be so much higher at a younger age. And also the technique of doing an amnio or CVS is really improved significantly, and we now quote about 1 in 1,000, 1 in 1,200 in good hands the risk of miscarriage. So what is the aneuploidy rate with age? So at age 25, it's about 1 in 475. Just 10 years later, you see the jump to 1 in 178 pregnancies. At age 40, it's 1 out of 60, and that's Down syndrome, Turner syndrome, all the trisomies and monosomies that are found in miscarriage products. And at age 45, 1 in 20. This is a study that was published by Ripple Genetics and was reported at the start through the CDC, and based on biopsying embryos. And there's a lot of questions about whether or not that's a true reflection of what happens in vivo. But you can see that the aneuploidy rate, again, when you take embryos on day 5 and you do a biopsy and you analyze it and you discuss the results with the patient, at age 43, over 80% will be chromosomally abnormal, and that's something that basically proved the point of the former studies that were done in productive conception after a miscarriage. This is a similar way of presenting it, or a different sort of way of presenting it. Again, you can see that even young egg donors who are 21 to 32 years of age usually, who donate eggs, and those eggs are fertilized with the husband or partner sperm or donor sperm, 60% of them only will be normal at that young age, which tells us that some of the embryos, even at the age 21 to 32, are going to be chromosomally abnormal. So that's something that we need to discuss with our patient. Young patients that are younger than 35 who do have infertility will have higher rate of aneuploidy because those are patients who struggle with infertility. But you can see the most important thing, that beyond age 42, that no matter how many embryos you have, you can see whether it's the first row or the last row, when a patient has a lot of eggs and over 10 embryos that are being biopsied, the statistics doesn't change and doesn't lie. About 9 to 11% of embryos only will be normal. So that means that patient will have to go through IVF after IVF until she achieves that viable pregnancy or viable embryo. This is a slide that I like to show, especially when interviewing medical students. This is the percentage of single women to single men in the U.S. So for all the residents in the audience, and you can see that New York has a very high ratio of single women, much more single women. So if you're single, maybe apply to UCSF. That's a better place to find a husband. And you can see that this is closer to home. This is right here in New York City. So you can see that we're right here in the Upper East Side of Manhattan, where the ratio of single women is much higher than single men. So usually when you have a week of vacation, or you have, you're night foot and you want to find a guy, usually go to Staten Island. That's where all the guys are. Okay? So we'll talk about a little bit about the history of cryopreservation. So cryopreservation of cells started in the mid-20th century. The first live birth from frozen sperm was 1953, but it took another 30 years until the first live birth from frozen embryo, and another 2 years until the first live birth from frozen eggs was achieved. And that's just, this slide alone tells us that men are much less complicated than women. You can see that. We can freeze sperm, sperm will survive, you can fertilize an egg, and the egg is a much more challenging cell. Over the past decade, an alternative to the old-fashioned slow freeze technique, the new technique is called vitrification, was developed, and that really revolutionized what we do in our REI offices, and revolutionized also the egg banking for egg donation. The outside cryopreservation using slow freezing developed about 40 years ago in 1972, and the eggs really did not survive very well. The thought process was that an egg has about 90% of its content of water, and then when you freeze it, the water will become ice, and it will break the membrane, the zona pellucida. So the thought process that if you basically slowly freeze it, it's going to protect the zona pellucida, which turned out to be the opposite actually. So they used to freeze it in batches of 1 egg per straw, or 2 at most, and drop the temperature by 5 degrees per minute or per 2 minutes. And then the whole process took a long time, and the eggs usually did not survive the freezing and the thawing. You'll speak to women in their late 40s and early 50s who froze eggs in the 90s and in the early 2000s, and you'll hear that most of their eggs did not survive, unfortunately. Some took a baby home, and that's the technique that we had back then. So they're really pioneers in freezing their eggs, but now the technique is really improved. The vitrification is a specialized freezing technique that basically rapidly freezes the eggs. So yesterday when we were doing a retrieval with one of the sabayas here, so the eggs were retrieved at 9 a.m. By 12 to 1 o'clock, all the eggs were already clean and frozen. Eggs can survive a long time in liquid nitrogen, as we know. Those that are placed in a bath with lower concentration of antifreeze, along with sucrose. The sucrose goes into the egg, the fluid gets out of the egg, and then the egg gets protected and survives the freezing and the thawing. And then when we warm the egg, we call it warming or thawing of the eggs, a year, a month, or 10 years later, you have to perform ICSI, intracytoplasmic sperm injection, because you just clean the eggs from all the granulosa cell around it, which are important for fertilization in vivo when it's happening in the fallopian tube. So that's something we have to discuss with patients, because when you freeze eggs, you also have to fertilize the eggs using an injection of the sperm into the eggs, which usually is not the traditional way of doing IVF. Vitrification is almost like a transition phase. It's not a liquid and not a solid, it's somewhat of a glassy amorphous state that basically protects the membrane. And this is really a schematic view of what the process of egg freezing during those few minutes that we're freezing it. And you can see that there is essentially preventing this I phase from forming by creating this glass transition state, and you basically gradually increase the sucrose and you protect the egg that way. So this is the old-fashioned way of freezing eggs, slow freeze. It was a gradual freeze. It took about 3 hours, much lower concentration of cryoprotectant, and now with a fast freeze, it takes 5 to 10 minutes. The embryologists will still complain that it's a lot of work, but that gives us a much better chances of survival and fertilization. So the American Society of Reproductive Medicine is an organization that basically approves all these new techniques in IVF, or at least reviews it and presents it to the CDC and the NIH to approve it. And all the REIs in the audience remember in October 2012, there's a big release, a news release, that basically egg freezing is no longer experimental. That's really changed a lot of things for us. It's been 6 years, and we all have seen a significant rise in egg freezing since then. It's actually now recommended for patients who are facing gonadotoxic treatment, whether it's chemotherapy or even radiation, in preparation for this treatment to try and salvage those eggs. So it's not just not experimental, it's actually recommended. And we get a lot of referrals now from the oncologists here at Sloan Kettering and other places that our patients are just diagnosed with lymphoma or breast cancer and are sent to our office to freeze eggs. And some of the team members here in the audience know that the patient comes in and a day or two later starts injection, 10 days later the eggs are frozen, and then 2 weeks later she starts chemotherapy, knowing that she has a good chance of conceiving in the future with her own eggs. What are the risks of egg freezing or oocyte cryopreservation? So first of all, you have to have your period. So you cannot use it on an 8-year-old who never got her period. There's other options which we're not going to go into today, but so that it has to be post-pubertal patient. The benefits, it's a really safe, well-controlled technique. We've been doing IVF in the world since 1978, so 25 million women underwent this procedure of in vitro fertilization. 5 million babies were born. When we were in school, there was one twin in each class, and everyone knew them by name. Now, it's pretty common. 2% of babies in the U.S. are born via IVF, and we use well-tested IVF protocols that are very similar in egg freezing. There are some changes, and I'll talk to you about it. And the risks have to be outlined to the patient. The risk of bleeding is about 1 in 500 to 1 in 1,000, depending on which study you look. The risk of ovarian hyperstimulation is real. Patients are usually paying out of pocket for this process and want to get as many eggs, so there's a communication with the physician. And how many eggs are you planning on getting? Are you going to be basically giving me a lot of hormones so you can get 30 or 40 eggs, or are we gonna play it safe and aim for a lower number? Infection, we go through the vagina. We usually don't use betadine, we just use water and soap, and the vagina, as we know, is not a sterile environment, so there's a risk for infection during the retrieval. Very small risk. Usually the patient will be giving antibiotics, either PO the night before for a couple of days or through the IV, especially if she has history of endometriosis or other conditions. We give those patients propofol. So just like with the colonoscopy and endoscopy, patient is undergoing conscious sedation. There's always risk when you do that. And then for patients who are diagnosed with cancer and any other medical disease that requires immediate attention, you delay their treatment by trying to harvest those eggs during those 2 weeks. So we'll focus from now on social egg freezing. The practice is not universal or standardized. So if you do egg freezing in Europe or in the US, it's maybe a little bit different. The technique of freezing the eggs is pretty standardized with the cryopreservation using the vitrification, but even that is ranging. Which media do you use, which vials do you use, which straws do you use. But in general, even here in New York, there's different philosophies, mini IVF, different IVF and so forth. So what I want you to be able to answer at the end of this talk is how many eggs a woman should freeze, at what age she should be considering that, when should she thaw it, does she get married and the day after the wedding she comes to thaw the eggs, or does she wait, and what are the risks and benefits. So age visit is something that I've introduced a couple of years ago. I think that this is very important for our general OBGYN in the audience. I think that now with the Pap smear being spaced out to 3 years instead of every year, and mammograms being pushed beyond age 40 for the initial screening, women are becoming like men. They don't see doctors as much. So you get to see your OBGYN every 2 or 3 years, and then during those 2 or 3 years, when you're 35 and the next time you see your OBGYN you're 38, a lot have changed in terms of your chance of conception. So I think that it's very important for us as OBGYNs and as educator to discuss ovarian reserve testing, to discuss the aneuploidy rate in the 30s, to discuss with the patient what she desires, how many kids she would like to have, even if she doesn't have Mr. Right now, what are her goals in terms of family planning, especially when the patients are over 35 years of age. Genetics, we now know that there's different panel, different companies that came up with a panel. Everyone knows 23andMe, and other companies that have very good marketing tools. We know now that a lot of patients are diagnosed with different genes that can put them at risk for cancer, whether it's BRCA for breast cancer and ovarian cancer, or other genes that can reduce their chances of conception, Fragile X, for instance. And I think it's very important to introduce the genetic testing before they're trying to conceive, before they're planning their family, because otherwise, the first time they'll do that genetic testing is when they're in their first trimester, right? They call their OB, I got pregnant, they come at 10, 9 weeks, and then they find out that they're carriers for several genes, and now it's a little bit too late. Most patients obviously will do amnio or CVS and continue with the pregnancy, but if you've given them that information, and usually it's covered by insurance, they may change the route they want to take. If they know they're Fragile X intermediate, or they know they have BRCA, they may decide to freeze eggs sooner or freeze embryos with their partner. And then the last thing is the E, that's the eggs or embryo freezing. Can't tell you how things have changed just in the last 4 or 5 years. There's a lot of REIs in the audience. A lot of patients come in, they get married, they come, we want to put some embryos on ice. We're planning on, getting our MBA, our PhD, and we'll see you, in 3 or 4 years. But we want to know we have 2 or 3 embryos to work with. It's almost like a future investment. So embryo freezing is also something that's become more and more popular. Google and Facebook help do that by covering their employees or giving them 1 cycle of egg freezing or embryo freezing. Northwell now covers the cycle, so I think that a lot of other health systems will go the same way because it's a benefit that most patients would like to have. Let's talk a little bit about AMH. AMH is anti-Mullerian hormone. I mean, when I was here a resident second year, that was my second year project, and that was about 2006. So in 12 years, AMH really got in, and everyone is right now running AMH when they're counseling patients regarding egg freezing. Back 10 years ago, I think it was still kind of like iffy. Can you check AMH while the patient is on birth control pills? Can you even go by this level? Do you need to repeat it every month and so forth? So now we have normograms, and we know that with the study that looked at 3,000 women aged 21 to 43, and we came up with some kind of number. So this is the slide that you may want to remember, but a lot of your friends will text you, listen, I just had an AMH, it's 1.6, what does it mean? right? The residents will tell you that that text gets forwarded to me automatically. So at age 25, AMH, average AMH, was shown in that study at least, and Ferguson started in 2011, and I think there's different normograms out there, but in general, it is high. When a patient has an AMH at age 35 of 2.3, it doesn't mean that everything is good and fine, see us in a year or two. It just means that right now, your egg quantity, and the focus is on quantity, not on quality, is preserved, okay? When a patient is 40, 5 years later, it's already cut down by half, and just 2 years later, it's already cut down by another half. So we know that, you know, it helps us, but it really helps us counseling patients who are kind of on the fence and not sure should they freeze eggs or not. A lot of the general OBGYN will want it as part of their annual panel or 3-year panel now with the pastor being pushed, and then they'll get a low result, and the patient will ask them, what do you do with that? And it's almost like put them in a tough spot. They tell her it's fine, and then 3 years later she's going to have a hard time getting pregnant, and she'll say, well, you ran AMH, why didn't you send me to a reproductive endocrinologist? So I think it adds some fear in the general population, but it gives you some tools to advise or counsel your patient and discuss at least whether or not you want to freeze eggs, embryos, and so forth. This is a New York Times article that came out, an op-ed of Sarah Elizabeth, who basically, I believe, froze her own eggs and then took it upon herself to bring it into awareness. Later on, there's a few other studies, a few other articles that basically promoted the egg freezing. This is a tool that was published by Brigham and Women, or a survey, I should say, that was asking women, why did you choose to freeze your eggs? You can see that 88% said the main reason was a lack of Mr. Right and Mr. Maybe. The 24% was professional reason, right? That was an OBGYN resident, I wanted to go for fellowship and do an REI and genetic fellowship, which is add another 2 years. By the time I'm ready to have family, I'm going to be in my late 30s and I want 3 kids. Do I give up that hope and so forth? So 24%. 15% were doing it for financial reasons, okay? They basically were able to afford egg freezing, and they said, why not? Or Facebook or Google covered for them. And some people chose not to do it because it was so overwhelming, injections and costs and so forth. So I think that cost is the main barrier, as we all know. A lot of other celebrities came about and said, I chose to freeze my eggs. That brought it into awareness. It's no longer taboo. You have patients in their late 30s who are single, who are sitting in the REI office. Obviously, we're not planning on having that discussion at age 38. Just broke up with my boyfriend and I want to have kids. But I think that this is really empowering when you know that a lot of women chose to do that. And the more we talk about it, the more it becomes accepted in society. What do we freeze, eggs or embryos? So it's a debate. If a patient is single, obviously it's a very big leap to choose a donor sperm and freeze embryos. It depends on the age of the patient. If the patient is single and 40, that's a different discussion, because as I showed you before, at age 40, less than 20% of the embryos will be chromosomally abnormal, and the last thing you want is to freeze a dozen eggs and tell her you're all good, see me in a year or two, and then when she comes back, all the embryos are chromosomally abnormal. So this at least has to be introduced. Choosing a donor sperm, this is where all the ex-boyfriends come to the iPhone, say, who should I freeze embryos with? A patient with severe male factor infertility. Those patients may choose to freeze embryos because their partner has low sperm count, and they know it's going to be challenging once they decide to actually have a kid. If there's medical indications, so a patient who's facing chemotherapy or has been diagnosed recently with endometriosis, which is very common in the infertility world, and they're single, should consider freezing eggs, and at the younger age, because as we all know, and our resident operate on a lot of endometriosis patients, a lot of them are in their 20s when they have lost one ovary or lost the bulk of an ovary for a cyst. And then there's ethical and social culture issues. So a lot of people don't feel comfortable freezing embryos and not using them, whereas with eggs they'll feel more comfortable. In fact, most of the studies came from Italy and Spain, when those are more religious countries that essentially promoted freezing eggs after IVF is being conducted, and they allowed only a certain amount of eggs to be fertilized with the partner's sperm, and only if they didn't get pregnant, they went back to the freezer, thawed more eggs, created more embryos, rather than fertilize all the eggs, get 10 embryos, and then have 2 kids, and then you have 8 embryos in the freezer. So that's another discussion to have with a patient. Embryo freezing, so the main thing, or main advantage is a lot of the insurance companies will cover IVF and embryo freezing. Most of them won't cover egg freezing. But that's where a patient will decide, maybe I'm comfortable with doing that. Wound-site vitrification requires experienced labs and embryologists. So, not every lab can freeze eggs, but pretty much every lab can freeze embryos because it's been around for a longer time. Genetic screening of embryos, that's a big advantage. So if you freeze embryos, you can actually do pre-implantation genetic screening and test and make sure that you have a normal embryo. So if I had to choose between freezing a dozen eggs or freezing one chromosomally normal embryo that gives you about 40% or so take-home baby rate, I would choose embryos over eggs because we don't know if they're going to survive, we don't know if they're going to fertilize, we don't know if the eggs are going to develop into a day 5 embryo, and then based on the age, you don't know how many of them will be normal. And then embryo freezing has been around, as I showed you, since the 80s, whereas egg freezing with the new technique has been around for about a decade or so. So I think that those are all important points. What are the risks in the lab? So you can see that this is the egg, and you can see that this is the meiotic spindle, and this is the zona pellucida. And when you freeze eggs, there's different organelles that are sensitive to the freezing and the thawing. So you want to essentially have the best technique, the best embryologist doing the egg freezing and the egg thawing, and you want to make sure that the embryo will survive the freezing and the thawing. The process itself takes roughly about 14 days from the time that they come to reproductive endocrinology, especially if they're already on the birth control or on day 1 or day 2 of their period and ready to go. It takes about 8 to 12 days of stimulatory medication, self-injected usually, subcutaneous injections. And then the egg retrieval, which is about 20-minute procedure, but it's a whole morning setup. They come, they do the retrieval, they get anesthesia, and then a couple of hours later they go home. So they'll meet with the REI, they'll have transvaginal ultrasound, they'll have an AMH, some other blood tests, and then we'll discuss the ovarian stimulation. Our nurses and team will educate them with online resources and so forth. And then this is the trigger shot that everyone is talking about 35 hours before. They're very nervous not to miss the time. It's usually done around 10 p.m. to midnight, so they're very nervous because it's 35 hours before the retrieval, and we don't do retrievals at 1 a.m., so thank God for that. And then essentially you decide if you're freezing eggs or embryos, and if you freeze embryos, whether you use the donor sperm or you use the partner sperm. So this is a diagram that shows the process, whether or not you use birth control pills, and for a lot of the young professionals who have a crazy schedule, a lot of us will decide to choose birth control just to time the egg retrieval so they can take time off from work, and essentially the process takes about 2 weeks. And during those monitoring sessions, you get about 15 minutes of visit with a blood test, an ultrasound, and a discussion with either a PA, a nurse practitioner, or a physician to discuss the process. And this is another diagram showing the same thing, recombinant FSH and a combination of the FSH and HCG, which mimics the recombinant LH are being administered, and then transvaginal ultrasound showing follicle growth. Those are some pictures of the subcutaneous injection. You have different medication there, ganirelix, follistim, Menopur, and other medication that we traditionally use in order to stimulate the eggs. The whole purpose is to try and recruit as many follicles and preventing the dominant follicle from releasing too prematurely. So that way you can get a cohort of a dozen or 20 eggs, or sometimes less than that, depending on the ovarian reserve, in one session. So some of the residents in the audience, I think Vladimir and Morgan are the only one who graduated here, the rest are on their way. This is some studies from Italy and from Spain by Cobo and Rienzi that showed essentially that the chances for implantation using frozen eggs and fresh eggs are very similar, and the clinical pregnancy rate for transfer with vitrification versus fresh, again, was very, very similar. Those are the studies that helped prove that basically it's no longer experimental. This is a study coming from NYU looking at 900 oocyte cryopreservation babies, and that showed a no apparent increase in congenital anomalies with 936 live born, and 1.3% were reported to have birth anomalies. This is the American Society of Reproductive Medicine practice guidelines that we review with our patient, and again, this is a summary of all the studies that say essentially fertilization rate and pregnancy rate are very similar with fresh versus frozen eggs. This is a tool that basically looks at the percentage of non-donor cycles resulting in a live birth for IVF. So we don't have 250,000 women who are doing egg freezing, but we do have 250,000 women doing IVF every year. So you tend to extrapolate from that data and tell the patient, if you're 35 years of age or between 35 and 37 and had undergone IVF, your chances of take-home baby rate would be about 30% per cycle. So that's roughly the number that you would expect. because even if there's a mild male factor, as I said, you have to inject the sperm, and usually that will give you a good fertilization rate of about 60 to 70%, similar to the fresh eggs being injected with sperm. And those are the studies that we have out there right now. We don't have, again, millions of women who froze eggs. The eggs are being frozen in liquid nitrogen in big tanks, usually 1 or 2 eggs in the straw, and multiple patients are being frozen at the same time in different tanks. So you want to make sure that all the hepatitis B, C, HIV, all the viruses are being screened before. And this is a slide that summarizes how many eggs have been shown to be beneficial, or what is the live birth rate with each number of eggs. So with 5 eggs for women who are younger than 35, so let's say a 33-year-old patient comes to you and wants to freeze her eggs, and she only had 5 eggs retrieved because of a low AMH or other reasons, it's about 15%. So you see it's about 3% per egg take-home baby rate. When that patient gets 10 eggs, it actually increases significantly. With 15 eggs, it's about 85%. So that's at the age younger than 35. This is a Brigham and Women's egg freezing counseling tool. It's called the EFCT, and you can actually plunge the numbers and look at the statistics. So if a 28-year-old froze her eggs, right, and got 25 mature eggs, that will give her about 95% of take-home baby rate. If she's 35 and she froze 15 eggs, you see there's a drop also in the eggs, it's about 83%. Still not bad number. But then, when you go to 41 and you got 10 eggs, that drops significantly. That's why most institutions will have some kind of an age cutoff and won't do it in patients who are in their mid-40s. The hospital field is one of the things that are becoming, the main burden. Office visit, ultrasound, lab work, the egg retrieval, the embryology field, the anesthesia, and then the medications. There is a tool called Fertility Drug Calculator, FDC, that you can actually plunge the medication that your doctor prescribed, and then it gives you all the pharmacies in the area and tells you what the rough price, the Metro Drug here, Aptor, different pharmacies that basically post their fees. And then we know that with good ovarian reserve, in addition to the cost of the egg freezing, there is a cost for the medication, and that can range anywhere between $2,000 and $6,000 per cycle. So that's an expensive process. In summary, the major advancements made with vitrification in the past few years have made egg banking a new development. So a lot of women freeze their eggs and can use it, but also younger women donate their eggs to older women via egg banking. You no longer need to synchronize the egg donor and the recipient. Recently, the demand for egg freezing, as I showed you today, for non-oncological indication have increased 5-fold in the past decade alone. Patient freezing eggs for non-medical indication, what we call elective egg freezing or social egg freezing, comprises those who are really at risk for having a reduction in the ovarian pool. So usually women who are single in their 30s will be the one who are freezing eggs. There's an increased demand seen in women who are over 40 who are now more aware of it and are comfortable with doing that. But this is where we come in as gatekeepers and discuss it. This may not be what you're looking for. It gives you a temporary solution, but you really need to start deciding whether or not you would like to have a child in your mid-40s, and egg freezing may not be the best tool. OBGYN should refer or should offer ovarian reserve testing as AMH, enteral follicle counts, FSH, and discuss the option of egg freezing. At least 8 to 10 mature eggs, what I showed you in that slide, are necessary to achieve reasonable success. If you go by 3% per egg roughly, that will give you about 30%, depends on which age of course, and numbers should be individualized for women who are older than 36. Women who desire to postpone childbearing should be encouraged to freeze eggs at a younger age in order to increase success, and maybe only do it once rather than go through this process 3 or 4 times in their late 30s, early 40s, and reduce the risk of abnormal embryos that are derived from those eggs that were frozen, and the cost remain the main stumbling block, as I mentioned. Thank you so much. I'll take a couple of questions and then we'll break for the interviews.